the person horrible reaction, vomiting, tachycardia, sweating. It's horrible. You have one sip of alcohol, you'll never touch it again. So that's the negative side of alcohol. The positive side works via this receptor here called the GABA receptor. And I showed it to you because here you can see alcohol in the bottom right-hand corner, but also other drugs act on this receptor, including benzodiazepines, Ambien, Valium, Xanax, Librium. All of these drugs act on the same receptor, propofol, the anesthesiologist in the audience. Gamma-aminio butyric acid, it's an inhibitory channel, chloride ions. But alcohol acts on a lot of other receptors too. The NMDA, that's the excitatory receptor. When you drink a lot of alcohol, this receptor becomes hyperactive, and it will lead to some of the complications we'll talk about later, like seizures. Dopamine receptor, the reward pathway, and this is fascinating, the corticotropin releasing factor, also known as CRF. This is your stress hormone. This plays a critical role in the development of addiction and alcoholism. And I'm going to talk a little bit about that in just a few minutes. But first, let's have another break. Leonardo Cappiello is an Italian artist. I don't know if anybody has seen these prints, maybe from time to time. Beautiful, aren't they? In 1906, they were made. He essentially was an artist who worked with a printmaker hired by alcohol companies to create these advertisement posters. This one here on the left for absinthe. And of course, that's the alcohol that Vincent van Gogh basically consumed before he cut off his ear. And then here on the right, this is an homage to the green elf fairy of absinthe. It's actually a different alcohol called quina, which is a cherry liqueur with quinine flavor. Interesting. I don't think they make it anymore. Diagnostic criteria also. Important to mention because it's changing. No more alcohol abuse or dependence. Really, we're talking about substance use disorder now. Okay, we're combining the alcohol abuse and alcohol dependence, adding in those craving and urges, and taking away any kind of recurrent legal problems that could vary from country to country. Mild, moderate, and severe criteria here. How many people actually have alcohol abuse and dependence? Here in the United States, over the last year, about 18% of Americans qualified for alcohol abuse. Over the lifetime, at any one point, about 5% of Americans can be given a diagnosis of alcohol abuse. Similar numbers for dependence. Statistically, alcoholism and addiction are equated with dependence, but really sort of a separate entity in a lot of ways. Addiction isn't disease per se. American Medical Association, the World Health Organization, American Society of Addiction Medicine have all shown this to be true scientifically. Dr. Benjamin Rush was the first physician to promote this idea as addiction and alcoholism as a medical disease rather than a moral failing. And that's reflected in current White House drug policy. It's really characterized by a compulsion to take a stimulus. And then when that stimulus is not available, there's a negative affect. There's sort of a negative emotional state that drives the individual to use again. If that's not simple enough, we can do A, B, C, D, and D's. It's abstaining, difficulty abstaining, difficulty with your behavior, continuous craving for this substance, whether it's alcohol or another drug, and then the problems that come along and the diminished recognition of how those problems are affecting the individual's life. There are risk factors for alcoholism and addiction. These are just a few of them. Young, single males. I wrote lower socioeconomic status here. Of course, here in the United States, that's relative. This is really speaking about worldwide access. Trauma, sexual trauma or abuse as a child predisposes that, and we'll talk a little bit about why. And then interestingly, a military background also predisposes an individual to have addiction. A lot of misconceptions when we talk about addiction and alcoholism. A lot of people think that the addict doesn't have a responsibility for their disease, their recovery. They're sort of using the medical disease as a cop-out, and that's not true. And I want to make that clear today. The addict does have responsibility for their actions and their recovery, despite it being a medical disease. Diseases can be a result of choices, as an addict frequently does, but importantly, It wasn't until about the 1980s or so that this idea really began to take place. And it was probably because of the work of this man, Dr. Bruce Alexander. He published a study in 1978 about rats in a cage, hitting morphine until they neglected their own need for water and food, showing that morphine was essentially very addictive. And that's where that idea came place. What we didn't hear about, though, interestingly, is that there was another group of rats that were placed in large fields, were given stimulation, plenty of group activity, played with stimulated, as opposed to the normally social white rats that were isolated in a metal cage. Those free rats didn't use morphine, even though they were given complete access to it. And I think this proves that there's a role for stress and socialization in addiction to drug use. How does the cycle start? Well, this gets back to those addiction risk factors I mentioned earlier. Things like physical trauma, sexual abuse, living in a war zone, etc. Those activities give you a low dopamine and a high CRF. Remember, that's that stress hormone we talked about. And that neurobiology imbalance predilects you to having difficulty with drugs and alcohol. Intentional use is at first, of course, probably at least 2/3 of us in this room have tried or drink alcohol at some point. But for the folks who have this predilection, this weakness, they become addicted. And it's those people that we need to help. A lot of people feel that they have a choice, and it's true at first. But once a biochemical threshold has been crossed, it ceases to become a choice. And this has really been proved time and time again by Dr. Koob and his research group at La Jolla Institute and the National Institute of Drug Abuse and Alcoholism. CRF, that's that stress hormone we talked about. It drives anxiety and craving. Important to mention, because we'll talk about that a little bit later. And this is the last slide I wanted to mention on this, and this is just a brilliant reduction of years of research that shows the different areas of the brain that are affected by addiction. This blue area here reflected by the sort of the purple picture here in the middle of the brain. This is the area of the brain that lights up with use, whether it's alcohol or another substance, that uses the neurotransmitter dopamine for reward. This is the binge and intoxication center. After that binge wears off, though, a withdrawal state and a negative affect takes place here, primarily in the amygdala and the ventral striatum of the brain. That is regulated in part by that stress hormone we talked about, CRF. And that activity drives a craving and a preoccupation also with that CRF hormone that leads back into that binge and intoxication. So it's really a neurochemical cycle that drives the addict to use. The genetics, we know that there is a genetic component. About 40 to 60% of all alcoholics and addicts have a genetic component. Even in adoption studies where an individual who was born from an alcoholic family or with a first-degree relative who's an alcoholic or an addict, they're removed from that home and placed in a home where alcohol is not used, they still have about 2 to 4 times the risk of alcoholism than somebody who didn't come from that family. We also know that people who drink alcohol and don't get a buzz or a high off that first drink are at increased risk for alcoholism and alcohol dependence, as opposed to somebody who drinks one and is buzzing. And now, my favorite part of today's lecture. This is a great little clip I found. At this clip, George and Jerry are at a Christmas party. And they have an acquaintance there named Dick, who's an alcoholic.
He's a recovering alcoholic.
Really?
Yeah, he's been off the wagon 2 years.
Off the wagon?
I think it's off the wagon.
I think it's on the wagon.
I think maybe Dick picked up yours.
Dick? He can't drink. He's an alcoholic. I told you to hold it.
I didn't know you meant hold it. I thought you meant hold it.
One drink like that and he could fall right off the wagon.
Told you.
Thanks for coming from you.
Oh, wait a second. I believe we have a heckler, ladies and gentlemen. Hey, Dick, look, I don't know what your problem is. It's not my fault you're back on the wagon.
It's off the wagon.
Well, in the old days, how do you think they got the alcohol from town to town?
I don't know.
On a wagon. Don't you think they broke into a couple of those bottles along the way?
You can't drink on a wagon, it'd be too bumpy.
They had smooth trails. What about the Cumberland Gap?
What the hell do you know about wagons?
Well, I know enough not to get on them. But in a way, I think I inadvertently turned this guy into an alcoholic. And I hate being around alcoholics because they're either telling you how much they love you or how much they hate you. And those are the two statements that scare me the most. But I think he's okay now because I have no idea how he feels about me. He's finally off the wagon.
You mean on the wagon?
Don't get smart.
Love that show. Okay. Let's get back. Hold on. There we go. Okay. All right. So sign up. Now let's change gears a little bit and talk about the outpatient area. You're in the clinic. You're at the school, etc. The United States Preventive Services Task Force, for those of you in the know, is probably the most conservative medical group that I've ever read recommendations for. They don't recommend anything unless there is evidence that it works. They recommend screening for alcohol use. It's been shown to, for those who are not alcohol dependent yet, reduce their total daily, weekly consumption, binge drinking effects, and the resultant harm, drunk driving, etc. that comes from that. They recommended multiple brief contacts between 6 and 15 minutes apiece. This is not a 30, 45-minute visit where you're hammering down on the person. You gotta quit drinking, you gotta quit drinking. That's not what they're talking about. It's brief, okay? Adolescents, they don't have insufficient evidence, mostly because the studies haven't been done. Recommended to screen by numerous other societies, ACOG, pediatrics, emergency physicians, surgeries. Most of them recommend SBIRT. And we'll talk just a little bit about SBIRT. It stands for Screening, Brief Intervention, and Referral for Therapy. Okay? This is what is recommended. Screening is universal. We're not just asking people who look like they could have a problem with drugs and alcohol. It's everybody. And we're asking them briefly just a basic question, which I will show you in just a moment. It's just a few minutes long, and we're targeting, if we find something, a specific behavior. And that can be as simple as, well, if you drink a lot but you're not sure, let's just count your drinks next time you go out. Or you drink 10 a night, what do you think we could cut down to 8 maybe? Or maybe avoiding some high-risk situations like being at the holiday Christmas party or being around people who drink a lot. And then lastly, we're going to refer folks who are having continued difficulty onto somebody who can help them, whether that's a psychiatrist, a counselor, or maybe someone like myself. How can we help? We mentioned a couple of these already, setting goals, including food, avoiding triggers, knowing your no phrase, and keeping it handy so that you can get out of a difficult situation that you find yourself in. Of course, if you find somebody who's having difficulty with alcohol, you want to go through the rest of your history and physical, make sure that they don't have other problems that can be complicated. Those diagnoses we talked about earlier with the bold sleep apnea, anxiety, etc. We also want to ask them about other high-risk problems like unstable angina that could contribute to a complicated withdrawal, mood disorders, pregnancy, etc. And when we take substance use history, not very common that we all do that. So we want to make sure that we ask them not only just when their last drink was, how much they drink on average, but if they're drinking or using other substances that could complicate a withdrawal. Have they ever had a history of withdrawal seizures, delirium tremens? How severe has it been in the past? Very important to know. Urine toxicology, laboratory studies also complete the picture. And lastly, these 3 words down here, audit, see, and CEWA. I'm going to talk about in just a second. They're in your handouts for those of you who want to take a look. We'll go through those in just a second. But first, when we ask an individual how much they drink, it's important to talk about the size of the glass. Okay, we saw that illustrated earlier with the guy who had the big wine glass and it was probably filled with 3 bottles of wine. Right? So 12 grams of ethanol, pure ethanol. That is what the United States defines as a drink. That varies from country to country. We're along the higher side. Austria, I think, is 6 grams. Japan is 20 grams of alcohol. So it varies a little bit, but for our country, it's 12 grams of alcohol, which you can find in a 12-ounce